So far, we have studied the location, anatomy and physiology of kidney. In this chapter, we are going to study the regulation of tubular reabsorption, tubular secretion, production of dilute and concentrated urine, as well as diseases of urinary system.
Here, we will study the hormonal regulation of tubular reabsorption and tubular secretion. In the renal tubules, there are 5 hormones that affect the extent of reabsorption of sodium, chloride, calcium and water as well as potassium secretion. These hormones include angiotensin-2, aldosterone, antidiuretic hormone, atrial natriuretic peptide and parathyroid hormone. Their mechanisms of action and effects are mentioned in the tabulated form. Now, we will learn the mechanisms of action and effects of all hormones in detail. The Renin-Angiotensin-Aldosterone system. When volume and pressure of blood decreases, the walls of afferent arterioles are stretched less and juxtaglomerular cells secrete the enzyme renin into the blood. Sympathetic stimulation also directly stimulates release of renin from juxtaglomerular cells. Renin clips off 10 amino acid peptide called angiotensin-1 from angiotensinogen, which is synthesized by hepatocytes. By clipping off 2 more amino acids, angiotensin converting enzyme abbreviated as ACE converts angiotensin-1 to angiotensin-2, which is the active form of the hormone. Angiotensin-2 affects renal physiology in 3 main ways. Number 1, it decreases the glomerular filtration rate by causing vasoconstriction of the afferent arterioles. Number 2, it enhances reabsorption of sodium, chloride and water in the proximal convoluted tubule by stimulating the activity of sodium hydrogen antiporters. Number 3, it stimulates the adrenal cortex to release aldosterone, a hormone that in turn stimulates the principal cells in the collecting ducts to reabsorb more sodium and chloride and secrete more potassium. The osmotic consequence of reabsorbing more sodium and chloride is excreting less water, which increases blood volume. Antidiuretic hormone. It is also known as ADH or vasopressin and is released by the posterior pituitary. It regulates facultative water reabsorption by increasing the water permeability of principal cells in the last part of the distal convoluted tubule and throughout the collecting duct. In the absence of ADH, the apical membranes of principal cells have a very low permeability to water. Within principal cells, there are tiny vesicles containing many copies of a water channel protein known as aquaporin 2. ADH stimulates insertion of the aquaporin 2 containing vesicles into the apical membrane via exocytosis, due to which the water permeability of the apical membranes of principal cell increases and water molecules move more rapidly from the tubular fluid into the cells. Because the basolateral membranes are always relatively permeable to water, water molecules then move rapidly into the blood. When ADH concentration is high, the kidneys can produce as little as 400 to 500 ml of very concentrated urine each day, for instance during severe dehydration. When ADH level declines, the aquaporin 2 channels are removed from the apical membrane via endocytosis. Now, due to lack of aquaporin 2 channels, the kidney produce a large volume of dilute urine. A negative feedback system involving ADH regulates facultative water reabsorption. Now, when osmotic pressure of plasma and interstitial fluid increases, means when water concentration decreases, osmoreceptors in hypothalamus detect the change. Their nerve impulse stimulates secretion of more ADH into the blood and principal cells become more permeable to water. As facultative water reabsorption increases, plasma osmolarity decreases to normal. A second powerful stimulus for ADH secretion is a decrease in blood volume. as occurs in hemorrhaging or severe dehydration. Atrial natriuretic peptide is also abbreviated as ANP. An increase in blood volume promotes release of atrial natriuretic peptide from the heart. ANP can inhibit reabsorption of sodium and water in the proximal convoluted tubule and collecting duct. ANP also suppresses the secretion of aldosterone and ADH. These effects increase the excretion of sodium in urine, that is natriuresis, and increase urine output, that is diuresis, which in turn reduces blood volume and blood pressure. Parathyroid hormone. Drop of calcium level in the blood stimulates the parathyroid gland to release parathyroid hormone known as PTH. PTH in turn stimulates cells in the early distal convoluted tubule to reabsorb more calcium into the blood. PTH also inhibits phosphate reabsorption in the proximal convoluted tubules, thereby promoting phosphate excretion. Production of dilute and concentrated urine. Generally, the total volume of fluid in our body remains stable irrespective of amount of fluid intake. Homeostasis of body fluid volume depends largely on the ability of kidneys to regulate the rate of water loss in urine. Normally, functioning kidneys produce a large volume of dilute urine when fluid intake is high, and a small volume of concentrated urine when fluid intake is low or fluid loss is large. ADH controls whether dilute urine or concentrated urine is formed. In the absence of ADH, urine is very dilute, whereas a high level of ADH stimulates reabsorption of more water and producing concentrated urine. How the dilute urine is formed? Glomerular filtrate has the same ratio of water and solute particles as blood. Its osmolarity is about 300 milliosmol per liter. When dilute urine is being formed, the osmolarity of the fluid in the tubular lumen increases as it flows down the descending limb of loop of Henle. The osmolarity still decreases as it flows up an ascending limb and the rest of the nephron and collecting duct. These changes in the osmolarity result due to several conditions along the path of tubular fluid. Number 1. Because the osmolarity of the interstitial fluid of renal medulla becomes progressively greater, more amount of water is reabsorbed by osmosis as tubular fluid flows along the descending limb toward the tip of loop. As a result, the fluid remaining in the lumen becomes progressively more concentrated. Number 2. Cells lining the thick ascending limb of loop have sympauters that actively reabsorb sodium, potassium and chloride from the tubular fluid. These ions pass from the tubular fluid into thick ascending limb cells, then into interstitial fluid, and finally some diffuse into the blood inside the vasa recta. Number 3. Although solutes are being reabsorbed in the thick ascending limb, the water permeability of this portion of nephron is always quite low, so water cannot follow by osmosis. As solutes but not water molecules are leaving the tubular fluid, its osmolarity drops to about 150 milliosmol per liter. The fluid entering the distal convoluted tubule is thus more dilute than plasma. Number 4. As the fluid continues flowing along the distal convoluted tubule, other solutes and only a few water molecules are reabsorbed. The early distal convoluted tubule cells are not very permeable to water and are not regulated by ADH. Number 5. Finally, the principal cells of late distal convoluted tubules and collecting ducts are impermeable to water when the ADH level is very low. Thus, tubular fluid becomes more dilute as it flows onward. By the time the tubular fluid drains into the renal pelvis, its concentration can be as low as 65 to 70 milliosmol per liter. This is 4 times more dilute than the blood plasma or glomerular filtrate. How the concentrated urine is formed? When water intake is low or water loss is high, such as during heavy sweating, the kidneys must conserve water while still eliminating waste and excess ions. Under the influence of ADH, the kidneys produce a small volume of highly concentrated urine. Urine can be 4 times more concentrated than the blood plasma or glomerular filtrate. The ability of ADH to cause excretion of concentrated urine depends on the presence of an osmotic gradient of solutes in the interstitial fluid of the renal medulla. The concentration of solute in the interstitial fluid in the kidney increases about 300 milliosmol per liter in the renal cortex to about 1200 milliosmol per liter deep in the renal medulla. Sodium, chloride and urea are the 3 major solutes that contribute to this high osmolarity. There are 2 main factors contribute to building and maintaining this osmotic gradient. Number 1, differences in solute and water permeability and reabsorption in different sections of the long loop of Henle and the collecting ducts. And number 2, the countercurrent flow of fluid through tube shaped structures in the renal medulla. Countercurrent flow means the flow of fluid in opposite directions. This occurs when fluid flowing in one tube runs counter or opposite to the fluid flowing in a nearby parallel tube. Examples of countercurrent flow include the flow of tubular fluid through the descending and ascending limb of loop of Henle and the flow of blood through the ascending and descending parts of the vasa recta. There are 2 types of countercurrent mechanisms existing in the kidneys. Number 1, countercurrent multiplication, and number 2, countercurrent exchange. We will learn both mechanisms in detail. Number 1, countercurrent multiplication. It is the process by which a progressively increasing osmotic gradient is formed in the interstitial fluid of renal medulla as a result of countercurrent flow. Countercurrent multiplication involves the long loop of Henle of juxtamedullary nephrons. The descending limb of loop of Henle carries tubular fluid from the renal cortex deep into the medulla, and ascending limb carries it in the opposite direction. Since countercurrent flow through the descending and ascending limb of long loop of Henle establishes the osmotic gradient in the renal medulla, the long loop of Henle is said to function as countercurrent multiplier. The kidneys use this osmotic gradient to excrete concentrated urine. Production of concentrated urine by the kidneys occurs in the various ways. Number 1, sympators present in thick ascending limb cells of loop of Henle cause a buildup of sodium and chloride in the renal medulla. In the thick ascending limb of loop of Henle, the sodium, potassium, chloride sympators reabsorbs sodium and chloride from the tubular fluid. However, in this segment, water is not reabsorbed because the cells are impermeable to water. As a result of it, there is a buildup of sodium and chloride ions in the interstitial fluid of the medulla. Number 2, countercurrent flow through the descending and ascending limb of loop of Henle establishes an osmotic gradient in the renal medulla. As the tubular fluid constantly moves from the descending limb to the thick ascending limb of loop of Henle, the thick ascending limb is constantly reabsorbing sodium and chloride. Therefore, the reabsorbed sodium and chloride become concentrated in the interstitial fluid of the medulla, which results in the formation of an osmotic gradient that ranges from 300 milliosmol per liter in the outer medulla to 1200 milliosmol per liter deep in the inner medulla. The descending limb of loop of Henle is very permeable to water, but impermeable to solutes except urea. Because the osmolarity of the interstitial fluid outside the descending limb is higher than the tubular fluid within it, water moves out of the descending limb via osmosis. This increases the osmolarity of the tubular fluid. As the fluid continues along the descending limb, its osmolarity increases even more. At the hairpin turn of the loop, the osmolarity can be as high as 1200 milliosmol per liter in juxtamedullary nephrons. As the ascending limb of the loop is impermeable to water, but its sympators reabsorbs sodium and chloride from the tubular fluid into the interstitial fluid of the renal medulla. So, the osmolarity of the tubular fluid progressively decreases as it flows through the ascending limb. Overall, as tubular fluid flows along the descending limb, it becomes progressively more concentrated, and as it moves along the ascending limb, it becomes progressively more dilute. Number 3, cells in the collecting ducts reabsorb more water and urea. When ADH increases the water permeability of the principal cells, water quickly moves via osmosis out of the collecting duct into the interstitial fluid of the inner medulla and then into the vasa recta. Due to loss of water, the urea remains in the tubular fluid of the collecting duct and it becomes more concentrated. The cells of the collecting duct deep in the medulla are permeable to urea, so it diffuses from the ductal fluid into the interstitial fluid of medulla. Number 4, recycling of urea causes a buildup of urea in the renal medulla. As urea accumulates in the interstitial fluid, some of it diffuses into the tubular fluid in the descending and thin ascending limb of the loop of Henle, which are also permeable to urea. However, while the fluid flows through the thick ascending limb, distal convoluted tubule and cortical portion of the collecting duct, urea remains in the lumen because cells in these segments are impermeable to it. As fluid flows along the collecting ducts, water reabsorption continues via osmosis due to presence of ADH. This water reabsorption further increases the concentration of urea in the tubular fluid. More urea diffuses into the interstitial fluid of inner renal medulla and the cycle repeats. Thus, the constant cycling of urea between segments of renal tubule and interstitial fluid of the medulla is termed as urea recycling. In this way, reabsorption of water from the tubular fluid of ducts promotes the buildup of urea in the interstitial fluid of the renal medulla, which in turn promotes water reabsorption. The solutes left behind in the lumen thus become very concentrated and a small volume of concentrated urine is excreted. The another type of countercurrent mechanism is countercurrent exchange. It is the process by which solutes and water are passively exchanged between the blood of vasa recta and interstitial fluid of the renal medulla as a result of countercurrent flow. The vasa recta also consists of descending and ascending limbs that are parallel to each other and to the loop of Henle. Just as tubular fluid flows in opposite directions in the loop of Henle, blood flows in opposite directions in the ascending and descending parts of the vasa recta. Since countercurrent flow between the descending and ascending limbs of the vasa recta allows for exchange of solutes and water between the blood and interstitial fluid of the renal medulla, the vasa recta is said to function as countercurrent exchanger. But entering the vasa recta has an osmolarity of about 300 milliosmol per liter. As it flows along the descending part into the renal medulla, where the interstitial fluid becomes more concentrated. Sodium, chloride and urea diffuse from interstitial fluid into the blood and water diffuses from the blood into the interstitial fluid. But after its osmolarity increases, the blood flows into the ascending part of the vasa recta. Here, the interstitial fluid becomes less concentrated. As a result, sodium, chloride and urea diffuse from the blood back into the interstitial fluid and water diffuses from interstitial fluid back into the vasa recta. the osmolarity of blood leaving the vasa recta is only slightly higher than the osmolarity of blood entering the vasa recta. Thus, the vasa recta provides oxygen and nutrients to the renal medulla without diminishing the osmotic gradient. Various diseases of urinary system. Number 1. Urinary tract infections. Urinary tract infections, also known as UTIs, is either an infection of a part of urinary system or the presence of large numbers of microbes in the urine. UTIs are more common in females due to the shorter length of the urethra. When it affects the lower urinary tract, it is known as a simple cystitis or a bladder infection, and when it affects the upper urinary tract, it is known as a pyelonephritis or a kidney infection. Symptoms from lower urinary tract include painful urination and either frequent urination or urge to urinate or both, while those of pyelonephritis include fever and flank pain in addition to the symptoms of a lower UTI. In the elderly and the very young individual, symptoms may be non-specific. The main causal agent of both types is Escherichia coli. However, the other bacteria, viruses or fungi may rarely be the cause. Uncomplicated infections can be diagnosed and treated based on symptoms alone. Oral antibiotics such as trimethoprim or sulfamethoxazole, cephalosporins, nitrofurantoin or a fluoroquinolone substantially shorten the time to recovery, with all being equally effective. Another disease of urinary system is a kidney stone. A kidney stone is a solid concretion or crystal aggregation formed in the kidneys from dietary minerals in the urine. Urinary stones are typically classified by their location in the kidney, that is nephrolithiasis, ureter, that is ureterolithiasis, or bladder, that is cystolithiasis, by their chemical composition. Males are more susceptible to kidney stones. Male most commonly experience their first episode between 30 and 40 years of age, while for women the age at first presentation is somewhat later. Kidney stones typically leave the body by passage in the urine stream, and many stones are formed and passed without causing symptoms. But if stones grow to sufficient size, that is usually at least 3 mm, they can cause obstruction of the ureter. Now we will see symptoms of kidney stone. The hallmark of stones that obstruct the ureter and renal pelvis is unbearable intermittent pain that radiates from the flank to the groin or to genital area and inner thigh. This particular type of pain, known as renal colic, is often described as one of the strongest pain sensations. Renal colic caused by kidney stones is commonly accompanied by the urinary urgency, restlessness, hematuria, sweating, nausea and vomiting. It typically comes in waves lasting 20 to 60 minutes, caused by peristaltic contractions of the ureter as it attempts to expel the stone. Now we will learn various treatments of kidney stone. Fortunately, surgery is not usually necessary. Most kidney stones can pass through the urinary system with plenty of water so that the stone move along with the water. Often the patient can stay home during this process, drinking fluids and taking pain medications as needed. The doctor usually asks the patient to save the passed stones for testing. It can be caught in a specific urine collecting container. First treatment of kidney stone is medical therapy. A doctor may prescribe certain medications to prevent calcium and uric acid stones. These medicines control the amount of acid or alkali in the urine, which are key factors in the crystal formation. The medicine allopurinol may also be useful in some cases of hyperuricosuriya. Doctors usually try to control hypercalciuria and thus prevent calcium stones by prescribing certain diuretics. These medicines decrease the amount of calcium released by the kidneys in the urine by favoring calcium retention in the pond. They work best when sodium intake is low. If cystine stones cannot be controlled by drinking more fluids, a doctor may prescribe medicines such as thiola and cuprimine, which reduces the amount of cystine in the urine. Another treatment of kidney stone is surgery. Surgery may be needed to remove a kidney stone due to some reasons. Number 1 is when stone does not pass after a reasonable period of time and causes constant pain. Number 2, if it is too large to pass on its own or is caught in a difficult place. Number 3, if it blocks the flow of urine. Number 4, when it causes an ongoing urinary tract infection. Number 5, when it damages kidney tissue or causes constant bleeding. Number 6, if it has grown larger as seen on follow-up X-rays. Extracorporeal shock wave lithotripsy is the most frequently used procedure for treatment of kidney stones. In this procedure, shock waves that are created outside the body travel through the skin and body tissues until they hit the denser stones. The stones broken down into small particles and are easily passed through the urinary tract in the urine. Ureteroscopic stone removal may be performed for mid and lower ureter stones. In this procedure, no incision is made. Instead, the surgeon passes a small fiber optic instrument called an ureteroscope through the urethra and bladder into the ureter. The surgeon then locates the stone and either removes it with a cage-like device or shatters it with a special instrument that produces a form of shock wave.
Over here, we have studied the regulation of tubular reabsorption, tubular secretion, production of dilute and concentrated urine, as well as diseases of urinary system. Not only this, but we have also studied various therapies which aids in the diseases associated with the kidney.